Proximal muscle weakness. General features. Look for signs that may give diagnostic clues to the causes of proximal muscle weakness. Table 19, particularly the following. Skin, e.g. purpura of steroid treatment, and much less likely malar rash in systemic lupus erythematosus, SLE, Gottron's papules, and heliotrope rash in dermatomyositis. Skeletal, e.g. joint swelling in SLE and rheumatoid arthritis. Endocrine, e.g. Cushingoid apprehensions in glucocorticoid excess and tremor in hyperthyroidism. Consider if this man could have myotonic dystrophy, which is very much commoner in PACEs than in routine clinical practice. Look for myopathic facies, drooping eyes/mouth and a sad and lifeless expression, ptosis, frontal balding and wasting of facial, neck and shoulder girdle muscles. In routine clinical practice also check the following factors. Cardiovascular, e.g. cardiomyopathy in alcoholism, amyloidosis, glycogen storage diseases, inflammatory myopathies, and muscular dystrophies. Gastrointestinal, e.g. hepatomegaly in metabolic storage diseases and amyloidosis. Neurological examination. Look particularly for muscle wasting and also for the presence of pseudohypertrophy of the calf muscles, most typically seen in Duchenne's or Becker's muscular dystrophy. It is very important to determine the distribution of the weakness, e.g. bilateral, proximal or distal, or more focal. If the patient has difficulty rising from a squatting position, hip muscles, or combing his hair, shoulder girdle, then the weakness is proximal. If the patient has difficulty standing on his toes, gastrocnemius and soleus, or doing fine movements with the hands, intrinsic hand muscles, then the muscle weakness is distal. If myotonic dystrophy is a possibility, try to elicit myotonia by asking the patient to grip your fingers as hard as he can, relax, and then repeat the grip and relaxation cycle a few times. Offer 2 fingers, but not more, or you may get hurt if the patient is strong. NB. Myopathy does not cause sensory signs. Do not diagnose a purely myopathic condition if sensory signs are present. NB. Do not forget to check whether there is also wasting and weakness in sternomastoid muscles, e.g. myotonic dystrophy, and facial muscles, some forms of muscular dystrophy or myotonic dystrophy. NB. Is the weakness fatigable? Think of myasthenia gravis. Don't forget to check for extraocular muscle weakness by examining eye movements. Further discussion. What are the causes of proximal muscle weakness? See Table 19. What are the causes of predominantly distal muscle weakness? Myotonic dystrophy, inclusion body myositis and genetic distal myopathies, the latter are rare. Muscle wasting. General features. Lesions that affect the ulnar nerve, T1 trunk, or cord of the brachial plexus, T1 nerve roots, or the equivalent group of anterior horn cells can all cause wasting of the small hand muscles. However, you need to establish whether the muscle wasting is limited to the hand or involves other regions as well, e.g. muscles in the shoulders or thighs, as the latter would indicate a more diffuse disease process, e.g. motor neuron disease, MND. Neurological examination. Cranial nerve examination. Are there any upper motor neuron signs indicating a pseudobulbar palsy, e.g. brisk jaw jerk, spastic tongue, or emotional lability? This would indicate disease involvement of the corticobulbar pathways above the brainstem, e.g. in MND. Are there any lower motor neuron signs indicating a bulbar palsy, e.g. poor elevation of the soft palate or tongue weakness and atrophy? This would indicate involvement of the motor nuclei of cranial nerves 9-12 of the brainstem. If the T1 nerve root is involved, e.g. in a Pancoast tumor, Horner's syndrome may be present. Limb examination. Are there any upper motor neuron signs, spastic tone, brisk reflexes, or extensor plantar responses? These would be found in spinal cord lesions, e.g. cervical myelopathy above the level of C5, or diffuse disease processes, e.g. MND. Are there any lower motor neuron signs, wasting, fasciculations, hypotonia or hyporeflexia? These would be found in MND, chronic inflammatory demyelinating polyneuropathy, CIDP, multifocal motor neuropathy, MMN, or spinal cord compression at the levels of C5-T1, indicating local anterior horn cell or radicular involvement. Sensory examination. In MND and MMN there is no sensory involvement. In cervical spondylosis, radicular findings often do not conform to textbook dermatomal descriptions. In CIDP there is often impairment of joint position and vibration sense, and less commonly of pain and temperature sensation. NB. MND and cervical myelopathy can sometimes be difficult to differentiate. The involvement of corticobulbar pathways, as suggested by the presence of a pseudobulbar palsy, would indicate the former as it places the disease process above the spinal cord. NB. It is crucial to differentiate MND from other potentially treatable conditions such as cervical spondylosis and MMN because of the better prognosis in the latter two conditions. Further discussion. What are common mimics of MND? Table 20. NB. Wasting and weakness restised to the small muscles of the hand, T1 lesion, should be considered the result of a Pancoast tumor until proven otherwise. Obtain a smoking history, look for nicotine staining and arrange a CXR immediately.